So this was a 50-something-year-old patient, came in with known history of PBC/autoimmune hepatitis. They were not sure which one, so some underlying liver disease, and the question was gallbladder. We did an ultrasound, we saw the same stone, and then we saw some other findings. So saw this rind of soft tissue surrounding the stone. And then
I'm wondering if there's areas where it looks like it's kind of going through the wall. On the
so that was one of the concerns too, like the enhancement in the wall was not
patchy,
smooth.
Yeah.
And that was the way the residents prelim this was concerned for acute chole. And then they subsequently did an MR, and here's the MR. So on haste, we again see that same soft tissue. Here's the stone. And this is what we were thinking was, to us, this looked more like circumferential edema in the wall of the gallbladder. There was more pericholecystic fluid down here, but a lot of this looked like it kind of followed the.
I agree.
Yeah, so then on diffusions, there was, of course, diffusion restriction. And I'll show you the pre-T1 first. As expected, all this was pre-contrast T1 hyperintense, because we thought this was some kind of inspissated sludge, and here's the stone. And on the post, typically with acute chole, we're used to seeing a lot more regional enhancement in the adjacent liver segments, which we didn't see. And on the post, the wall looked better than it did on the CT. So I think there was less concern that it was some kind of complex chole.
And do you have subtractions? Did it?
Yeah, that's exactly what I was going to show. So these are subtractions, which accounting for the little misregistration, I don't think there was a whole lot of enhancement. So if this was mass of any kind, we would have expected the subtractions to show real enhancement. The only thing that we thought about, we pulled up a bunch of papers which talked about tumefactive sludge versus true gallbladder masses. And a lot of them talked about diffusion being an important differentiating factor, where sludge would not restrict as much and definitely would not enhance, of course. This one on the high B values, it did look like there was persistent diffusion restriction, and it was quite low on the ADC. But I think given how—
what about instead of sludge, like abscess or infection or something?
So the white count was normal. So that's interesting you say that, because the way it was prelimed was, it's very suspicious for an abscess. But patient really was not sick enough, no SED rate, CRP, no elevated white count. More of her labs showed LFT elevation, which was thought to be secondary to her liver disease. There was acute liver injury. They even did a liver biopsy, which showed significant acute bile duct injury from ongoing, like active PBC. So in the end, we ended up saying all this is most likely sludge, tumefactive sludge with a big sludge ball, despite the diffusion restriction. And then we thought the smooth and concentric T2 signal around the gallbladder wall was just more reactive to the adjacent liver disease. And she had some third spacing from some heart failure issues as well. Then the wall particularly didn't look discontinuous or irregular. There was not much pericholecystic inflammatory stranding. The surgeons were a little unsure what to do. She was not a surgical candidate anyway. The one thing we told them confidently was we didn't think it was a gallbladder malignancy. So I think that helped them. And then eventually they ended up getting a cholecystostomy tube. And when they stuck the tube in, they said all they got was 15 to 20 ml of very thick inspissated greenish bile. They sent the fluid for culture, and it has not grown anything so far. So I think it's kind of a challenge to call it upfront with the diffusion and whatnot, but in the end, it turned out to be more of a chronic process than acute. So it's a good recap of what tumefactive sludge could look like.
Yeah, it's interesting. The papers you read, you said that they said that tumors will have more restricted diffusion than sludge, but they didn't say that sludge won't restrict diffusion, right?
So they said there's a very good AJR paper, I think it's the most recent one. They did say in passing that, remember that inspissated sludge, which is very cellular, can have diffusion restriction. So they gave that as a caveat. But we really didn't see any other secondary signs, no nodal disease, no real nodularity of the wall. So we were confident that if it's not a gallbladder malignancy, but just struggle between calling it acute coli versus tumefactive sludge only, and then the cholecystostomy tube findings definitely have confirmed.
Yeah, that's a good one. And it's interesting about the edema, like, because the lumen doesn't look too distended. Like you said, there was no hyperemia of the adjacent liver. So that would go against acute coli, but like just that amount of gallbladder wall edema when the LFTs aren't elevated, or, so I guess probably related to maybe their cardiac thing.
Right. Hepatitis and cardiac issues.
Yeah.
Yeah.
Excellent.
Okay.
Okay. So this patient came in with a positive pregnancy test. And you can see that there is a gestational sac, as well as a little yolk sac and a fetal pole. And we are getting a fetal heart rate of about 160 beats per minute. This is the right ovary, other ovary also looked fine. And here's some markings on here, but what do you guys see?
Is it IUD?
Yeah, so this was a patient who got pregnant despite an IUD being in place. You can see that the IUD is pretty low. It's in the cervix, and then it's kind of deviated and going into the myometrium here. I'll show you with cine. So there's our fetal pole high up in the cavity, the rest of the endometrium here, and then we've got that IUD that's mostly in the cervix, and then kind of going out into the myometrium there. So just a few things I looked up about pregnancy in when the setting of having an IUD. This is actually pretty rare. IUDs are thought to be about 99.5% effective, but not 100%. So it can happen. When it does happen, it's more common to happen if the IUD is low lying, for example, in the cervix. The IUDs are much less effective. If they're in the cervix, they're thought to be 3 times less effective. So that's when you could possibly get the intrauterine pregnancy. And then ectopics are also more common, not because the IUD causes ectopics, but because it's so rare to get an intrauterine pregnancy when you have an IUD. There is a higher rate of getting ectopics when you have an IUD. And the other thing I learned is that if possible, they will try to remove the IUD. So they will go and pull the strings out, especially if it's early enough. They'll try to remove this because there is a higher risk of especially infection, as well as preterm labor and other complications. So in this case, they could not find the strings. And so since it's mostly not in the endometrium, they're opting to leave this IUD in place. And yeah, so this was just a rare case of a pregnancy that happened with an IUD. And I'll just show you, there's a cute little baby that went viral on TikTok because they came out of the womb apparently holding their IUD. So I'll show you the picture. So here's the babe, and he's holding his IUD. And the baby came out holding the IUD. So all the nurses were in shock. So
Aarti, if they ever remove these, what do you know what trimester is a good time to do it?
As early as possible, basically. Yeah.
Okay.
But some of them, like, they'll leave them in place and there have been successful pregnancies with them. There's just a higher rate of infection. I think there was actually, like, out of the NIH, a multi-center, multi-country paper that came out about 10 years ago that showed that there is a significantly higher rate of infection if you have an IUD in place. Nice. So they have to be monitored very carefully. Okay.
Okay, so 79-year-old female who came in with pelvic pain. And this was the scan. So main finding is in the pelvis, of course.
I saw that big cystic and solid mass with like enhancing septations localizing to the left adnexa.
Right.
Looks like the uterus is out. It's also causing hydro.
There is hydro.
And then what's that fatty mass in the mesentery? Wait, go down. Oh, wait,
Yeah.
and we're like also studying around that fatty mass, like peritoneal disease.
So great observation, yes. And then one more finding up in the abdomen.
Oh, there's like fluid along the hepatic capsule. It looks like more peritoneal disease. So I'm thinking when you think of fatty masses, we often think of like dermoids or teratomas. So I'm wondering if that ovarian mass has peritoneal disease, but part of it was part teratoma.
Okay, that's a good thought. There was no fat in this whatsoever. And first time around, we thought this was an adnexal mass also. We did say it's kind of next to the sigmoid, but they had already done a colonoscopy and ruled out it was nothing exophytic coming from there. Couldn't really follow the gonadal vein. So patient was thought to have an ovarian mass.
Wait, can you show the rind like anteriorly? Like the uterus is definitely out, right?
Yeah, there's no uterus really. She's older, she's almost 80, so couldn't see either ovary definitively.
Okay.
So all this was outside imaging. So they decided to operate on her based on outside imaging alone. And when they opened her, they actually found this to be arising from the appendix. And when you look back retrospectively, I guess this is the dilated appendix. And a small component of it is here. And I don't know how, but it exophytically entered the left hemipelvis. And then the gynonc said there were a lot of lymph nodes in the vicinity of the cecum and the appendix, which we can see now. But it was very confusing because the bulk of this mass looked like it's on the left side, causing mass effect on the left-sided vessels and whatnot. And it turned out to actually be an appendiceal mucinous.
The appendix tricks us again.
Yes, it did.
It's like even when you think anything is anything, you should always make sure that the appendix is normal.
Right. So this was all omental disease, and you picked up this very subtle nodularity along the surface of the liver, which they did a PET CT concomitantly, and you can see all of the liver disease much better. Here's that node which is hot, and then the liver disease was really nicely seen along the capsule, like focal areas of pericapsular uptake, compared to like these parts where there wasn't much.
That's interesting because if it was just mucinous tumor, if it was just like, for example, low-grade appendiceal mucinous neoplasm lamin, I think those are usually not very PET avid because it's mostly mucin, acellular mucin. So this is probably more in the like mucinous adenocarcinoma.
Yeah, this was a high-grade tumor. And like you said, histopathologically, they do talk about differentiating between is the mucin cellular or acellular. The acellular ones, they say the recurrence rate and pseudomyxoma peritoniae risk is less than 10% or so. Versus if it's cellular mucin, the risk of PMP is much higher, 30-40%, which makes sense in her case because she already has omental medicine.
I was going to say this looks more like the cellular adenocarcinoma because of the nodularity rather than just like fluid causing scalloping and stuff. Wait, so what about the fatty thing? That's just like
that's just an omental infarct or an epiploic appendage or something.
Oh,
it happened to be encapsulated because the omental cake around it. But it was interesting that the hydro was on the left side. Everything pointed to a left-sided etiology till the surgeon opened it and said, no, it's all, the appendix had like perforated. Everything was coming.
Yeah. And actually that's tricky because if we think it's ovarian, then gynonc will go in. But if it's appendiceal with peritoneal disease, you might be thinking about a hypec. And so you really need surgery.
So that's kind of what they're doing now. So inadvertently, GYN opened it and they said it's inoperable. So now SONC is seeing her and they will do hypec.
Cool. I haven't heard that term SONC, but so for surgical oncology.
So,
Interesting.
Yeah.
So what do you guys think of this case?
see a catheter of some sort.
Yep. So that was a VP shunt in the abdominal wall and then entering here. And it kind of goes along the hepatic dome.
All
And
that loculated fluid around the liver.
exactly. So this was kind of like a VIPoma, but it happens to be in the subcapsular space. So we think that basically when they were placing the shunt, it dissected into the hepatic capsule, and now it's basically just all contained in the subcapsular space and causing mass effect on the liver capsule. So when you have these VIPomas or VP shuntomas, like you can CSFomas, you can get them in the abdomen. You can get like an encapsulated fluid collection. It can actually, these shunts can also dissect into bowel, but in this case, it dissected into the hepatic capsule. And so if too much fluid accumulates here, that can actually cause mass effect on the liver. It can eventually rupture. It can rupture into the liver as well. So they actually went and revised the shunt as soon as this started happening. The patient basically had increasing right upper quadrant pain, which makes sense because the capsule is being pushed here.
Not seen subcapsular like this.
Yeah.
Okay. So another older patient comes in with history of vaginal bleeding, and they wanted us to evaluate for any possible vaginal mass. So this case and next case, I just want to show the importance of distending the vagina with ultrasound gel. It's really helped us in picking up small things and tumors and recurrences. So
yeah, it looks like thickening evil gray along the right posterolateral vaginal wall, beautifully shown with that vaginal gel. Did you guys know this was for a vaginal thing, or when do you use gel? We use it for like our endometriosis protocol, but other than that, we haven't put. It's maybe cervical cancer protocol.
yeah, so in most GYN cancers now, we've been using these, especially when they have a PET CT, which shows something small, and we know we're looking for something really small. I'll show you one more case that really helped us there as well. So like you said, this was that evil gray irregular wall thickening and nicely seen on diffusions, nodular areas of restriction. And I thought the sagittal showed it really nicely. So very plaque-like tumor spanning anterior wall, posterior wall, compared to the smooth looking left lateral vaginal wall. Good preoperative information for the surgeons. So staging wise, this was, we call it a T2 because T2 for vaginal cancer is tumor invades the paravaginal tissues, but does not extend to pelvic side wall. And T3 is when it actually goes to the side wall. And this patient, despite being T2 disease, they did not do a vaginectomy in this. They've been doing chemoradiation and watching her. And I'll show you the most recent follow-up.
And it was squamous cell, or?
It was adeno, actually.
Okay.
It was adeno. Share screen again. So here's follow-up scan. So we can see most of the gray signal is gone and just replaced by more hypo-intense looking scar tissue. And again, there was no extension to the side wall. There was no regional adenopathy. They did do a PET CT concomitantly. There's no other disease. So just well controlled on chemoradiation. But this vaginal gel has really helped us. Another follow-up case, and I will pause for a second. Okay, so we were discussing importance of vaginal gel in these GYN tumors. So this was another 50-something-year-old lady who came in for staging scans for endometrial cancer. And these are just her T2-weighted images pre-operatively. So how would we have staged this?
It's definitely going into the myometrium.
And
Is it going beyond? I don't definitely see it going beyond.
yeah, so we didn't think it was going beyond either. So we said it's based on local, it's at least a 1B because it looked like it was invading more than 50% of the myometrium, especially here, it looked very thin in the fundal area. So at least a 1B based on local staging. She did get a PET CT concomitantly. There were no other lymph nodes. So didn't call it, I mean, preoperatively, it would have just been a 1B. So the interesting thing that happened was there was a 3-month gap between her getting surgery and this scan for whatever reason. And when they went in to operate her, they found that this had invaded the rectovaginal septum and the pelvic side wall, which retrospectively, even when I looked at the scan, I don't think we could have called anything at that point. We just thought these were normal ovaries, and there were some fibroids, of course. So it had grown pretty much in 3 months that it had become inoperable at that, not inoperable, it was advanced. They still did a hysterectomy anyway. And then she came back with this
Wait, I have a question about those ovaries. Like, do you know if
Yes.
the ovaries were involved? Because I'm just thinking in retrospect, like I have seen some endometrial cancers that like essentially had grown into the adnexa.
So it's interesting. Yes, the ovaries were involved. That's what I
They
meant.
look a little weird there, right? Like a little
I know.
gray.
They're a little gray, right? Now that you look at it, it's a little gray. But they did say it was like kind of fixed to the sidewall, fixed to the rectovaginal septum, lot of regional nodes and whatnot. So I think more significant progression than what we had appreciated here. So that's why from 1B, she became a 3B at surgery. And then she comes back with this palpable vaginal nodule, which again has the same evil gray T2 signal, very nicely seen on post-gel images, and then kind of had heterogeneous enhancement. So this got biopsied as well, and this is recurrent endometrial adenocarcinoma deposit, very low in the vaginal wall.
That
So
is really nice to see.
Yeah.
I'm curious if you called, what did you call about the urethra? Like it looks like it's pushing the urethra, but not definitely invading.
So on this, the requisition actually said rule out urethral diverticulum. But I mean, it was closely abutting, but we didn't say it's invading. And it was separate, but it was very close is what they said on the path also.
Nice.
Yeah, but from what looked like a 1B, this just became very
That is one thing that's really tricky. And obviously this isn't really up to us. And, but you know, sometimes my surgeons have told me like that they've been burned if they don't get an updated imaging right before the surgery, which is really tricky because they're, you know, all the scheduling is very complicated, but you know, when things spread and then they like get in there and they're like, wait, this looks totally different than what I was expecting a few months ago, you know?
Yeah, and even for patients to expect this type of recurrence, and now she's going for an anterior vaginal wall vaginectomy. So it's 2 big surgeries back to back.
Yeah.
Yeah.
Okay. So this was a youngish female in her 30s.
SPEN.
Great thought. It was not a SPEN, I'll tell you. But I would agree with you. Young female, round lesion that looks cystic and solid, big solid component. So definitely thinking SPEN, even more than MCN. But although the location would be great for an MCN, it almost looks like it has a claw sign, body tail junction, rounded lesion. MCNs usually have more septations and then develop solid components. Okay, so that was the first scan. Then the patient got an MRI. This was the MRI.
Fluid hematocrit level.
Yeah, so there was a fluid hematocrit level, and all of that stuff that looked like solid stuff on the CT wasn't actually really solid.
Pseudocyst with hemorrhage.
Yeah, I'll show you so this was the diffusion. So there appeared to be some restricted diffusion layering stuff, but it's layering so much that we know that this is not soft tissue, either abscess or hemorrhage. It's T1 bright, so definitely hemorrhage. And then I will show you the post contrast. There was this filling defect here that also did not enhance. And then this is the subtractions. And you can see the whole black hole. So what looked like enhancing soft tissue on CT was not enhancing on MRI. We now have a hemorrhagic fluid level. So still confusing. It still looked well circumscribed. There wasn't a great history for pancreatitis. So people reading this said, like, you know, we favor this to be an MCN, maybe with some complication, with some hemorrhage. Did you guys poke it? What happened to it? They hadn't aspirated it yet. But still unclear. MCN, probably not SPEN, because SPEN will have some enhancing component.
Even for MCN, there's no enhancement at all, right?
Yeah, 10% of MCNs will be unilocular. Actually, probably even more than 10%. Sorry, that was for liver MCNs. But yeah, there's plenty that are unilocular, not as many that have, like, you know, a layering hemorrhage level. But just 4 days later, this is what it looked like.
Oh, ruptured.
So it had ruptured. And there was a lot of inflammatory change around it. And then a couple more, like a couple of weeks later, it's starting to wall itself off. There was actually a frank disruption of the duct. So they ended up putting in this pancreatic duct stent, this very long stent. There was a subcapsular collection developing along the spleen, and there's probably some pancreatic juices traversing into the pleural space. So they aspirated this, the amylase and lipase were super high. There was actual, when they went in on ERCP, there was a disruption of the duct. So this was a pseudocyst. The interesting thing is she didn't have a great history for pancreatitis, but sometimes people don't. And it looked so well walled off initially, like this was the first presentation of it. And yeah, it was just interesting because even at this time, we probably shouldn't call this a pseudocyst because that's only after 4 weeks, but whatever it was kind of looked well circumscribed, but then it was already a ductal disruption and the fluid was accumulating so rapidly that it ruptured within a couple of days. So just a tricky case, but I've been tricked the other way where I've called something a pseudocyst and it turns out to be an MCN. So when you've got this like questionable history, rounded lesion, young patient, it is worth aspirating to kind of put it to rest. In this case, you know, time just kind of revealed itself as it ruptured and then eventually showed that the duct was actually disrupted. So
yeah, the other problematic pancreatic lesion we see is the microcystic lesions, right? On CT, they can look so solid almost because you cannot delineate the tiny cysts. Still, you do an MR.
absolutely, absolutely. So MR definitely helps in those situations. So anything that looks possibly cystic in any way, recommend MR. Anything that doesn't look like a classic adeno, I would recommend an MR. But then in this case, the MR still didn't really help us because we still said like the differential is pseudocyst versus cystic neoplasm.
Yeah. This is actually a follow-up of a case that I presented before. And it has to do with the consensus guidelines for LMS. And the question that I have is, with the LMS, one of the key things that we're supposed to look for is T2 heterogeneity, or, you know, non-T2 hypointense. So if it's T2 hypointense, then you're done. But if it's T2 heterogeneous, then you go on to the pathway, right? Where you look for DWI signal, that's hyper to endometrium, and then ADC less than 900, excuse me. My question is, so this is the case of a fibroid uterus, and this was a pedunculated fibroid, actually. If you look at this, there's a stalk here. So would you guys like just call this T2 hetero, or would you just call this fibroid? To me, it looks like a benign fibroid. But if you're going to apply the LMS pathway, like, would this fall into the heterogeneous category, or like how would, I mean, I'm just struggling with some of these fibroids that look benign to me, but if you look at the T2 signal, it's hetero. So, I mean, are we supposed to go down?
This is exactly what we talked about when you showed it the first time, and I was supposed to pull if we should apply the algorithm in this case, and I have not yet asked her, but
oh, good. Okay, good. Because All right, please ask her, because actually I had another patient two patients actually in the interim that had similar T2 hetero. Well, it doesn't look exactly like this, but so I mean, clinically, what would you guys call this pedunculated? Let me give this.
I would call it a fibroid.
Yeah, it looks like a fibroid, right? I mean,
and I don't think I would apply the algorithm because the majority of this is pretty T2 dark, but that was exactly the debate / question last time, is like, does the majority matter? Or because a lot of fibroids are heterogeneous with areas that are intermediate. So then you would be applying the algorithm to quite a few fibroids.
That's right. So when do we apply it, and when don't we?
Nelly,
So
this still looks fairly organized. Like, even though it's heterogeneous, it's like not as chaotic as what most LMS would look like, right? With large areas of cystic changes, large areas of hemorrhage or necrosis. This still looks somewhat organized to me.
well, I don't think cystic changes and disorganization are features of the pathway.
But I see what Roopa's saying. It still looks well contained.
Yeah, like benign.
Organized, not aggressive looking.
Yeah, this was surgically proven benign fibroid.
Yay, we had that follow-up.
Yes. So, and I would love to know what Nicole thinks in terms of when we should call it hetero, because we see plenty of heterogeneous fibroids that we're now going down the LMS pathway because it's hetero, and I don't think that's appropriate.
Nelly, if you did, where would you calculate the DWI on this?
Where would I calculate on this?
Where would you put your ROIs?
Well, the pathway says it should be in the area that's enhancing.
Right.
So I would probably, let's see, where would it, I mean, this is a hetero area.
Okay.
Like, to me, this doesn't, I mean, here, so it's enhancing. So maybe somewhere along that area. And the DWI signal has to be higher than the endometrium. So in that, let me see if we can. So like here, it looks pretty hyper relative to the endometrium. So that's my thought process. I don't know if it's helping or not, but maybe if this is the endometrium, then I would
you got
look at the
greater
area
than
where there's
900 on ADC.
I think so, yeah. Let me see if I can pull up the screenshots. Yeah, I got less than 900. Is that what you said?
Yeah, I meant more. Yeah.
Yes. So I got less than 900, yes.
Okay, before I post this, I will ask Nicole.
Here, let's see.
And I'll send her a
This
video.
is where I ended up measuring it. It was 835, 850. And it has to be what? The circumference has to be like 25 or 20 or something like that, or
20.
Yeah, about
20.
25.
Okay.
Yeah, I have a similar one we called yesterday. We favored it as a large fibroid because we were getting in the 1100 range, the DWI. So we'll have follow-up on that when I'll show it when we have.
Yeah, I think it's just, I mean, now I'm backing off of when I apply that work, because it creates a dilemma for our gynecologists. And I think it causes more problems than it's, problem. I mean, it doesn't, I don't know, it causes more problems than it's worth.
Okay, so this was a patient with flank pain. Left flank pain. Any thoughts?
Very enlarged kidney. A lot of perinephric
It's like
fluids.
there's stranding, and it looks like, I don't know, is there infection or inflammation?
Yeah. Is there a stone also?
Not a stone. The main finding is on this image, and I know I'm scrolling for you.
Oh, a mass around the UPJ.
Yeah. So, and actually, like,
But it's very fatty looking. Is there? Do you have the fat suppressed images?
yes. Oops.
Oh.
There's arrows now. Sorry. But anyway, what I was trying to show you on the T2, which I think it was a nice.
Oh, it's just
example,
inflammation.
actually.
It was just inflammation, just dirty.
Right, but there's like
Yeah.
the flavoid of the renal vein is gone. Okay, and then even here, the flavoid in the IVC is gone. Right, so this is nice flavoid, and then this is
Yeah.
non-flavoid. So some kind of thrombus, either tumor or bland thrombus. So we go then to the post-contrast. This was the arterial phase, a lot of enhancement in that part, but then up here, this is actually bland thrombus up here. That's not enhancing. And then the tumor thrombus here, I'll just tell you that it is tumor thrombus mostly in the renal vein. But when we went to the kidney, we didn't actually see a mass in the kidney per se that we could definitely say like all of this even did not restrict. It was mostly in the vein here. And then leading up to this bland thrombus in the IVC that goes, and you want to tell them the level of both the tumor thrombus. So tumor thrombus went right to the IVC junction, and then bland thrombus went to the infrahepatic IVC, which is important because you don't have to necessarily call in a hepatic surgeon to like, if it goes all the way up to the hepatic venous surgery, they did a nephrectomy. I was being asked, do you think this is renal cell or urothelial, given that we don't really see a mass here? Can you guys still see my?
Yes.
Okay, said my internet was unstable. But anyway, I said I still favor RCC. I have seen rarely urothelial cause tumor thrombus, but most commonly it's RCC. And even if we don't see like a real mass here, maybe there's like an infiltrative part here that started in the cortex that mostly grew into the vein. The reason it would make a difference is that with urothelial, they would do a nephroureterectomy, so dissect the ureter all the way down to the bladder, whereas for RCC, mostly just a nephrectomy. They ended up doing a nephrectomy and they dissected most of the ureter as well, because preoperatively, they felt like they could not safely biopsy this, like it was mostly in the vein. And the path came back a grade 4 clear cell RCC that was almost exclusive, or basically at least pathologically, it was exclusively in the vein. There was no mass in the kidney and it didn't involve the renal cortex or parenchyma. So it was really interesting. Then my urologists were asking me like, how is it possible? And it reminded me of like the HCCs that are mostly tumor in vein. And when I've asked Claude about this, he was like, well, it has to have started from some hepatocyte somewhere. So even if it started in like one cell and then grew into the vein, it started in the liver. So that's my theory here, is like it started from some renal cell that we couldn't really, and none of this was infiltrative tumor in the kidney. So anyway, it started in some cell and it mostly grew in the vein. And like we predicted, it was RCC because that's much, much more commonly going to be growing into the vein. If it had been more something we could have biopsied ahead of time, that would have helped. And then the other thing I learned from my urologist is that on frozen section, the pathologist will not tell you intraoperatively if it's RCC or urothelial. They need to do a lot more stains and investigation to do that. Because I was asking them, like, they were like, well, it makes a difference. It's much more extensive surgery to resect the entire ureter all the way down into the pelvis. And it could lead to a bladder injury, et cetera. And I asked, like, well, why can't the pathologist do a frozen? And they said that they won't tell them RCC versus UCC in the OR. So just an interesting case, mostly tumor in vein of an RCC that was a grade 4.
It's like LRTIV with the infiltrative HCC.
Exactly. But sometimes even in like HCC, we don't see where it is in the actual organ of origin, So.
This is a patient who had a prostate MR and had biopsy proven. This is probably the most suspicious lesion. This was biopsied and it was grade group 2. So Gleason 3+4. So then patient, actually, I don't know if it's grade group 2 or 3, which is 4+3, but it's Gleason 7. And patient had a PSMA study, so that there's focal PSMA uptake here. And the area that was also expressing PSMA was in this bone lesion here. So what are your thoughts about that?
Nelly, does the MR cover, does the T1 on the MR cover that area?
Let me the T1 here. It would be here in the sacrum, right there.
What I've learned is that PSMA is a misnomer because it's not prostate specific. And so I
Yeah.
always ask my nuclear medicine people. I've heard of other things that can cause PSMA activity, including like, I think neuroendocrine tumors or like other kinds of tumors, but I don't know about bone lesions that also could cause it.
So this was biopsied and it was negative. So PSMA, exactly, like PSMA can be taken up by hemangiomas in the bone. So it's
It can also be taken up by hemangiomas in the spleen, or no, hematoma in the spleen. We had one that was PSMA active, I think.
oh, is that right? Okay. So our nuclear medicine radiologists, if there is just mild uptake, right? This wasn't like focal high uptake. If there's mild uptake and it's single or isolated, then we're recommending tissue diagnosis, and not just passing it off as bone mets, because there are false positive, because non-prostate things can take up PSMA.
Nelly, did this patient have a bone scan?
Yes. The
Okay,
bone
just keeping
scan
differential.
was negative.
Okay. Nice.
It seems like, why wouldn't they recommend then follow-up versus a biopsy?
Because the patient was being prepped for surgery.
Okay. And maybe if the PSA is high enough, they'll be like, okay, we really need to know.
Right, yeah.
Okay, thank you.
Thank you, everyone.
Thanks all.